Good morning. The 21st Lourdes Manahan Lectures in Rheumatology is now streaming live from the University of the Philippines, Manila. I am Dr. James Barte of the Division of Rheumatology, UPPGH, moderating this session. So I'd like to thank our sponsor, Taisho, and all our participants for joining us today. October is Bone and Joint Awareness Month, and this year's theme, it's in your hands, take action. We are inviting everyone to join us in our month-long activities to raise awareness of the existence and impact of rheumatic and musculoskeletal diseases. So this October 14, we are inviting everyone to join us for the opening of our exhibit at the PGH Elevator Lobby, where we will showcase artworks and educational posters to raise awareness regarding bone and joint conditions. So we hope to see everyone there. So just a few reminders before we begin. Please post your questions at the Q&A box and we will address them during the open forum. You will receive your certificate of attendance after you submit the evaluation form and post-test. The link will be posted later, and be sure to type your full name and email address to receive your certificate. So this is the 5th year that we are doing the LMLR online. The LMLR aims to teach rheumatology to healthcare professionals, an advocacy initiated by Dr. Lourdes Manahan, the first Filipino rheumatologist. So this year's theme is Reaching Treatment Targets Together. We wish to emphasize a holistic understanding of our patients and their diseases, as well as strategies through which we can make our patients' lives better. LMLR is in support of the WHO Sustainable Development Goal number 3 on health and well-being, and SDG number 4 on quality education. The Division of Rheumatology has its book publications, the Atlas of Rheumatic Diseases in the Philippines, as well as the Physician's Guide to Telerheumatology. And those who wish to purchase copies can do so through our contacts. We also have the following educational booklets. Bawal ba munggo sa rayuma? OA ba ang rayuma ko? Arthritis ba itong back pain ko? Gout ba itong rayuma ko? At rayuma or rheumatoid arthritis. So these booklets will be available at our exhibit at the PGH Elevator Lobby starting October 14. So come and visit our booth if you want to grab a copy of these booklets. So today's lecture topic is particularly relevant, as osteoarthritis is one of the most common joint conditions worldwide. Managing osteoarthritis is not just about treating the symptoms. It's about learning how to live well and maintain quality of life despite the condition. It is my great honor to introduce our esteemed speaker for today, Dr. Auxencio Lorenz A. Lucero. Dr. Lucero earned his Doctor of Medicine degree in De La Salle University College of Medicine. He completed his residency training in internal medicine in San Juan de Dios and his fellowship training in rheumatology in the UP-PGH. He is an associate professor in De La Salle Health Sciences Institute and the current chairman of the Department of Internal Medicine in San Juan de Dios Hospital. He is also the chief of the section for rheumatology both in San Juan de Dios Hospital and in De La Salle University Medical Center. He is the current president of the Philippine Rheumatology Association. So ladies and gentlemen, let us all welcome Dr. Lucero as he shares his expertise in today's LMLR.
Good morning, everyone. First off, before I begin, I'd like to take this opportunity to thank the Division of Rheumatology for inviting me to be a part of this Lourdes Manahan Lectures in Rheumatology. And the topic that was assigned to me for today is about osteoarthritis, particularly on this one, living comfortably with osteoarthritis. So these are my disclosure, and as an additional disclosure, this talk has been sponsored by Taisho. So for today, I only have two objectives, and that is at the end of my lecture. I hope everyone here will be able to discuss OA as a disease and also discuss the role of a new topical NSAID in the management of osteoarthritis. So this will be the flow of my discussion, and we will keep on coming back to this slide. So let's begin with the burden of disease. So OA is the most common arthritic condition. If you look at the table in your screen, prevalence of OA has increased from 4.8% to the present estimate of 7.6%. And since that time, there's been a corollary increase in the number of cases and the contribution of this condition to disability worldwide. So the growth since 1990 has been at least 130% in both the number of cases and the contribution of this disease to disability. Now, this is more commonly seen among females, and the most common joints involved are the knees, hands, and hips. Now, globally, OA ranks number 14, but if you only take into consideration the more elderly population, 70 years old and above, then it ranks within the top 10. And among the different types of OA, knee osteoarthritis contributes the most to this disability. Now, the quality of life of OA patients is also affected. So in this study by Vitaloni et al., a systematic review, they included 62 studies, inclusive of almost 25,000 patients, uh, all of them diagnosed to have knee osteoarthritis, made up predominantly of elderly female. So they measured the quality of life of patients with knee osteoarthritis, and they used different instruments, such as those listed here, to measure the quality of life. And the results show that whatever instrument was used, the quality of life of patients with osteoarthritis was always worse compared to those without this condition. And poor outcome factors were related to the female gender, to the obese weight, to being sedentary, to those being poor or having mental health issues, and those having poor family support. At the same time, you probably noticed that a lot of our patients with this condition have existing comorbid condition. And in this study by Swain et al., they wanted to see the prevalence of comorbid conditions among patients with osteoarthritis. So in this systematic review and meta-analysis, they included 42 studies, inclusive of around 1.6 million OA patients, predominantly female. And the results show that 2/3 of patients with OA have at least one comorbid condition. And the most commonly seen are stroke, peptic ulcer disease, and metabolic syndrome. Now, we do have our own data for prevalence, and it comes from two studies, the National Nutrition and Health Survey done in 2003 and the earlier studies by Copcord in 1991 and in 1997. In the latest study coming from the National Nutrition and Health Survey, it shows that OA is the third most common arthritic condition behind gout and RA, which is in contrast to the two previous Copcord studies, where it clearly shows that OA is the most common arthritic condition in the Philippines. However, despite this discordance, what is apparent in the data is that there is increasing prevalence with age. So OA is more commonly seen among the middle-aged, the elderly population. It commonly involves the knees and the hands, similar to the global data, and of the spines. So it's seldom that we see involvement of the hips, ankles, and shoulders among Filipinos. Now, in terms of presence of comorbid conditions, There were two local studies that looked into this. First one by Pitzer et al. In 2008, and the other one by Zamora et al. In 2012. And these two studies show that the prevalence of comorbid conditions is anywhere from more than half to two-thirds of patients with osteoarthritis. The most common conditions seen among Filipinos are hypertension, diabetes, and dyslipidemia. And in the study by Zamora et al., a fourth one can be included, which is obesity. And predictors of disability among Filipino patients with OA were related to the severity of pain and stiffness, and also those with higher weight. Now, we are expecting that OA will continue to be a public health issue in the coming years because of three important factors: the continuing population growth worldwide, the aging phenomenon, and the increase in obesity. By 2050, it is expected that there would be around 1.1 billion OA patients, and this is corollary to the increase in the growth of the elderly population worldwide and even in the Philippines. Now, in terms of obesity, it has actually increased significantly since 1990, according to the latest data from the WHO, which is placed at around 16%. And even in the Philippine population, whether you're looking at the male or the female population, there's also been a corresponding increase in the obesity rate in the country. So what do we know now about this condition? So I will not be discussing pathophysiology in detail, but I will just highlight with you what we now know about this condition. So we don't see OA anymore as a simple wear and tear disease. The present paradigm is that OA is actually a failure of the synovial joint as an organ. And therefore, it does not only involve the articular cartilage, but also the subchondral bone, the synovium, and all the periarticular tissue surrounding the joint. And we now know that it is actually an interplay of three important factors: inflammatory, metabolic, and mechanical. So what you have is a certain patient profile with coexisting comorbid condition, and a certain event triggers the process. So this process is actually an inflammatory process where the catabolic event outpaces that of the anabolic event. So what you have in the end is what we recognize in the clinic as osteoarthritis. And there are several risk factors that predispose patients to develop this condition. Those that we cannot do anything about, they are called non-modifiable factors, and they include age, gender, genetics, and anatomic factors. Those that we can still modify are under modifiable factors, and they include obesity, heavy work, repetitive joint use, and major injuries. So we now know how OA behaves. So the most common reason why patients come to the clinic is because of joint pains. And according to this theory of diminishing organ reserve, in the beginning, when the organ reserve of the synovial joint is still very much intact or close to normal, then pain is few and far between. And if it occurs, it's usually of short duration. However, as the organ reserve starts to diminish, then pain becomes more frequent and even of longer duration, until such a time that the organ reserve, the critical mass of the organ reserve is breached. And here, patient becomes more consistent or even more constant in a lot of these patients. Now, there is a diagnostic criteria published by the European guideline, EULAR. And in this criteria, they tell us that you only need clinical information to be able to diagnose patients with osteoarthritis. So in this criteria, if your patients have symptoms and signs referable to the knee or the hand and supported by these common risk factors, then the probability of a correct diagnosis increases to as high as 99%. And imaging may not be really important in the diagnosis of osteoarthritis and should only be considered depending on what you gather from your history and physical examination. So again, I just would like to highlight that imaging is not necessary to make a diagnosis of osteoarthritis. And the only time that you probably need to request for an imaging test would be one, if you're entertaining a different diagnosis, two, if your patients remain symptomatic despite treatment, and three, if there is a typical presentation in your patient. And if you're considering imaging test, then the conventional X-ray should be the first modality to consider. And if you do an X-ray, these are your typical findings. You will see osteophytes, subchondral sclerosis, joint space narrowing, and the presence of subchondral cysts. Now, if you notice, despite the development of new therapies or even introduction of new treatments in the market, a significant proportion of our patients remain symptomatic or even have progressive loss of functionality. And the main reason for this is because a lot of the modalities that is available for us at the moment is only marginally effective at decreasing pain, with the probable exception of surgery. Okay? And therefore, main reasons for this. Number one, there seems to be difficulty in detecting the disease in the earlier stages of the condition, where present research is now telling us might be the window of opportunity of intervening more significantly for this disease. Second, the slow progressive nature of OA is actually a problem for research. So it takes a long time before you actually see significant changes related to the disease activity. Third, the measures that we use to detect disease activity in OA seems to be insensitive. And a very good example of this one would be the use of X-ray for detecting, for example, joint space narrowing in osteoarthritis. And lastly, if you probably notice, there seems to be significant heterogeneity among patients with osteoarthritis. So for example, if you give a certain treatment, it works for some patient, but it doesn't work in another set of patients. And this last factor would be the one that I would be discussing in more detail in the succeeding slide. So if we accept that OA is heterogeneous, the question that comes to mind is that, is OA really just one disease? Or is it a collection of many driven by these different factors? And present research is telling us now that there may be multiple underlying pathways that eventually lead to a common pathway that we identify in the clinic as osteoarthritis. So in this context, we should now look at OA really as a syndrome rather than a single disease. And so if we accept that OA is a heterogeneous disease, then we need to define two important terms, phenotype versus endotype. So phenotype refers to the observable characteristic or traits in an individual. And this usually results from the interaction of your own genes with that of the environment. And a good example of this one is, for example, obesity in patients with osteoarthritis. Endotype, on the other hand, refers to the underlying mechanism that explains the condition, or in some um, journals, they define it in terms of treatment response targeting this particular molecular mechanism. And there are advantages of understanding phenotype or endotype. Okay. So number one, it gives us a new way of understanding osteoarthritis. So it tells us who among our patients would respond well to a particular treatment, or who among them will have a good or a bad outcome. And more importantly, it will tell us the underlying mechanism for that particular phenotype. So overall, it will impact positively in the way we care for our patients with osteoarthritis. Now, the question that comes to mind is uh, this proposal by Del Isola et al., where they wanted to see whether there are already existing clinical phenotypes in the literature. So in 2016, they did a systematic review, and after searching the literature, they were able to identify 24 studies. And the main aim of this study was to identify the existence of distinct clinical phenotypes among patients with knee osteoarthritis. And after looking at these 24 studies, they were able to identify 6 phenotypes as shown on here, and I will explain them in more detail in the succeeding slide. And the authors tell us that while these 6 phenotypes are distinct, they're not mutually exclusive, and that in a patient, there is a possibility that some of these phenotypes can actually exist in an individual. And the authors also tell us that while these proposed clinical phenotypes may not fully explain the heterogeneity that we see in patients with knee osteoarthritis, this is already a good starting point for research. Okay, so what are these 6 clinical phenotypes? So for those with chronic pain, this refers to patients with heightened pain sensation, or those suffering with peripheral or central sensitization. Those with metabolic syndrome refers to patients with high prevalence of metabolic factors, such as those with obesity, diabetes, hypertension, and dyslipidemia. Those with mechanical overload are those patients who have excessive mechanical forces acting on a specific areas of the joint. So we see this in patients with malalignment, such as those with genovarus or genovalgus. Those with inflammation characterized by the presence of synovitis or effusion. Those with abnormalities in bone and cartilage metabolism, and therefore characterized by the presence of certain biomarkers. And those patients with low degeneration or only presenting with mild clinical symptoms and therefore expected to have slow progression over time, and they are under the minimal joint disease phenotypes. Okay. So the same set of authors wanted to see whether these proposed clinical phenotypes can already be used in existing registry of cohorts of patients. So in 2018, they followed up the study. They were able to identify 599 patients with knee osteoarthritis. All of these patients came from the OA initiative database. Okay, all of them were diagnosed to have knee osteoarthritis, and they had definitive criteria for each of these clinical phenotypes. Okay? So the main aim was whether they can be able to classify these 599 patients into one of these clinical phenotypes. And the results show that they were able to classify 84% of these patients into one of these phenotypes. And in 20% of these 84% had overlap, and they labeled them as having complex knee osteoarthritis. And the remaining 16% remained unclassified. And the authors explained that there are two main reasons for this. Number one, the definitions they used to classify patients into one of these phenotypes were either strict, or second, the other explanation is that there might be other clinical phenotypes that have not yet been um, detected in the literature or identified in the literature. So if we accept this clinical phenotyping, then we can actually personalize treatment in these patients. So for example, in patients with chronic pain, they might respond well to the use of cognitive behavioral therapy, education, and exercise. Those with metabolic syndrome might probably respond well to diet and exercise. Those with mechanical overload would do well with the use of biomechanical interventions, particularly the use of wedge insoles, canes, or knee braces. Okay. Those with inflammatory phenotype might actually do well with the use of anti-inflammatory drugs, inclusive of the use of intra-articular steroid injection. Those with problems in the bone and cartilage metabolism might do well with the use of drugs that target abnormalities in these areas. And those with minimal joint disease might probably do well with just conservative management. And so while these phenotypes might tell us that we might be able to individualize treatment, this is still not universally accepted. And so while awaiting for the acceptance of these newer concepts in osteoarthritis, the best source of management for our patients would still come from published clinical guidelines. Okay? Now, all of these guidelines have three important goals, and these are alleviation of pain, improvement of function, and to delay progression of condition. And they can range from the core treatment, which is non-pharmacologic, to the adjunctive treatment of pharmacologic treatment. And if these two modalities fail, then surgery can be an option for our patients. So we won't go through all of the existing clinical practice guidelines. So because luckily late last year, there was this systematic review of clinical practice guidelines that was published. And they looked at all of the CPGs that were published from 2015 to 2022, particularly for adult OA patients. So for these studies, they were able to identify 20 CPGs. 11 of them were appraised to be of high quality. Okay. And what they did was to stratify all of the recommendations in these different CPGs to should do, could do not do, and no consensus. For the should do, this should be applied to all patients, and the main core of treatment should always include education, exercise, and weight loss. For education, in the Western countries, they have formal classes. So what patients do is that they enroll to these classes and they are taught what these conditions are and what they can do to address their pain. However, in the Philippines, we do not have this yet, but what we have is what we call the standard clinic encounters. And this is what we do at the moment at the clinic. We already tell them what they have, the diagnosis, and what they can do to manage their condition before they can actually go to us for further management. Exercise should always include strengthening, aerobics, and flexibility or neuromotor exercises. Now, there's no consensus on the best exercise for all patients. But what is recommended is to individualize the exercise program for these patients. And what is important is to progressively add weight, or if you're using weights, to your patients with osteoarthritis. And for weight loss, this is best for patients who are overweight or obese, and the minimum recommended weight loss would be anywhere from 5 to 7.5%. And the literature is telling us that there is better symptomatic relief with greater weight loss. The others should do includes the use of hand orthosis in patients with hand osteoarthritis. And overall, management should always be patient-centered, taking into consideration also the patient preference and not just our own management as doctors. For pharmacologic treatment, NSAIDs should be the first line of treatment, whether oral or topical. And as I have highlighted, if the non-pharma or the pharmacologic measures do not work well to your patients, then that is the time to consider for surgery. For could do, all of those listed here can be used in your patients depending on the clinical situation. And for the do not do, all of those listed here have been shown to not benefit patients with osteoarthritis. And lastly, the no consensus only tells us that there is no recommendation for or against the use of these modalities because of insufficient evidence at the moment. And therefore, you can still use some of these modalities depending on the clinical situation of the patients. Now, if you notice, a lot of the treatment modalities that are listed in the different clinical practice guidelines only address pain. And we know that pain is only just one dimension in the management of osteoarthritis. So there's this guideline from the NICE guideline from UK, which also lists uh, a lot of psychosocial factors that we also need to consider in patients with osteoarthritis. And these are the common concerns of our patients. However, this list might seem daunting to the attending physician. And therefore, I just would like to highlight that not everything that is listed here would be of concern to all patients with osteoarthritis. However, if you're able to pick up specific concerns in your patients, then that should warrant further consideration in your management. Okay. And before I end this talk, let me just share with you this last study from PGH. So they wanted to see whether there's a correlation between a good family support with that of the quality of life of Filipino elderly patients with knee osteoarthritis. So for this study, they were able to enroll 90 patients, and the results show that in patients with good family support, there's actually a significant reduction of the disabling symptoms in terms of reduction of pain and stiffness and improvement of function in patients with knee osteoarthritis, thus highlighting the important role of family in promoting wellness and positive behavior toward illness. And therefore, again, highlights another dimension in the management of OA, not only taking into consideration the patient in the management, but also have important family members in the management of this condition. So this ties up very well with the culture of Filipinos of having a closely knit family. So that ends the first part of my lecture. So let me just summarize what I discussed with you today. So OA will continue to be a public health issue in the coming decades because of three important factors: the continuing population growth worldwide, the aging demographics, and the rising uh, rates in obesity. Second, there continues to be management gap in osteoarthritis because a lot of the treatment modalities that we have are only palliative in nature. And lastly, if we really need to enhance the quality of life and therefore ensure that our patients live comfortably with their condition, then we need to have a comprehensive strategy integrating the latest know-how of what science is telling us regarding this condition, and then making sure that we personalize treatment in our patients and incorporating multidisciplinary care in our patients. So with that, so that ends the first part of my lecture. So earlier in the lecture, I told you about a new treatment modality that is available in the market. And this is coming from the pharmaceutical company Taisha. And they have a new product called Locoa with the active ingredient S-flurbiprofen. So I've already discussed in detail about management, so we will not go through that anymore. But I just would like to share with you this another study from UPPGH describing the most commonly used drugs that we use here in the Philippines in the management of osteoarthritis, and they are as follows: glucosamine sulfate, paracetamol, and NSAIDs. And we know that the use of NSAIDs can lead to adverse drug reactions such as systemic side effects. It can affect the heart, the kidneys, and even the GI tract. And a lot of the topical NSAIDs that are available uh, is still wanting in terms of its effect because a lot of them have poor tissue penetration. So there's still an unmet needs in patients with osteoarthritis. So what we want is to have a medication with good effect and is safe to use on a long-term basis that is suitable in our patients with a lot of comorbid conditions. So we want a drug, comparing it with existing oral medications with less risk of systemic side effects, and comparing it with existing topical NSAIDs, have a strong active ingredient and have a high absorption ratio. And luckily, we have that now, a new or innovative NSAID patch coming from Taisha. So this is Locoa. This is a transdermal patch. Each patch contains around 14 milligrams of the active ingredient S-flurbiprofen. And the main indication for use is in patients with osteoarthritis. You can use a minimum of 1 to a maximum of 2 patches per day. So this was first launched in Japan. So it was developed using Japanese technology. So it started in 2016 and then later on launched in Thailand and Malaysia in 2021, where the current market share is number 4 and number 1 respectively as of the latest data in the early 2024. And here in the Philippines, it was launched late last year, but it was made fully available only this year. So if you prescribe it in your patients, the patch comes in a pouch. And this is how the pouch looks like. It can be resealed once open. And each of these pouch contains 7 patches. So this is how it looks like in the front. and at the back, it contains more information about the drug and the manufacturer, and also the instruction on how to use this particular medication, and the caution of not using more than 2 patches per day. So this is how the patch looks like. It's color orange or beige or flesh. And what you're looking at is the front part covered with a transparent film. So you need to remove the transparent film. And once removed, you can already apply the sticky part to the affected area. So what are the evidence for the use of this drug? So they applied this patch to healthy adult males in the lower back. And then after 24 hours, they looked at the pharmacokinetic properties of this patch. So it shows that it can be absorbed significantly in the plasma, and the Tmax is anywhere from 17 to 18 hours with a half-life of 8 to 9 hours. So if you add this one, it tells us that this patch can actually provide 24-hour relief and therefore convenient to use as a once-a-day medication. And absorption can reach to as high as 50%. Now, they use this patch in patients with knee osteoarthritis. And what is unique with this particular study is that all of the patients that were enrolled in this study were already scheduled for knee replacement. So what they did is that they applied the patch to the affected area 12 hours before the procedure. And then they wanted to see whether this new patch has better improved or improved transdermal absorption, and whether it can penetrate into the deeper tissue such as the synovium or the synovial fluid. And they compared it with a previous patch called florbiprofen patch. And the results show that S-florbiprofen has a better absorption, 7 to 8 times better compared to the previous patch, okay? And it can actually penetrate better into the deeper tissues as the concentration of the drug was detected in the synovium and in the synovial fluid at a more significant level compared to the older patch. So with this information, you're assured of this patch being effective and therefore can reduce inflammation into the deeper tissues. Now, this patch is also very potent in inhibiting the COX-1 and COX-2 enzymes, and they are much more potent compared to existing topicals in the market, such as ketoprofen and diclofenac. Okay. So there's this study comparing S-florbiprofen to the existing diclofenac gel. So this is a randomized but an open-labeled study enrolling patients with knee osteoarthritis. At the end of 2 weeks, both treatment arms actually decreased pain in patients with osteoarthritis, and the results show that there is actually no difference between the two. So S-florbiprofen is not inferior to the effect of diclofenac gel in terms of decreasing pain in patients with osteoarthritis. In terms of safety, they use this drug continuously for 52 weeks, and they look at the adverse event that can occur in these patients. So in this study, they enrolled 201 patients. Half of the patients used 1 patch, and the other half used 2 patches, and they were commonly applied to the knees or to the spines and a few on these areas. And the most common adverse drug events were mostly detected on the local site where it was applied. particularly dermatitis, eczema, erythema, and pruritus. Okay? And the adverse drug reactions were mostly mild to moderate, and none of the AEs were rated as severe. And there were also a few systemic adverse drug reactions, but they were considered to be very minimal side effect. In terms of efficacy, they also looked at the clinical symptom outcome. So they used 7 components as listed here in terms of pain symptoms, inflammatory symptoms, limitation of motion, and activities of daily living. And if you look at the graph below, there was improvement in the patient's symptom, whether you're looking at the area where it was applied from the time that it was applied to the assessment starting at 2 weeks after application up to the end of the study at 52 weeks. And this is also true when you look at the individual improvement in the clinical symptoms from 2 weeks to 52 weeks. So you now have a new topical NSAID that can be used as a first-line treatment in the management of pain with osteoarthritis. It can be used as an add-on to existing analgesic in your patients. It can be used on a long-term basis, even in patients with coexisting comorbid conditions. Okay? So before I end, let me just highlight the features of this new topical NSAID. It has a high transdermal absorption and with good tissue penetration. It has a strong COX inhibition for both COX-1 and COX-2 and therefore expected to have good analgesic effect. It has a favorable safety profile with minimal systemic exposure. And lastly, as shown by the last study I shared, it has significant and consistent symptom control, even on long-term use as long as 52 weeks. So with that, presenting to you once again, Lucoa with the active ingredient S-florbiprofen. So thank you for listening and good day.
Okay. Thank you very much, Dr. Lucero, for that wonderful lecture. There were a lot of significant new knowledge in understanding OA as a heterogeneous disease. So right now we have an increasing number of questions already from our participants. So we'll start first with the basics, the clinical features. So our participants wanted to clarify if shoulder pain is considered an osteoarthritis, since from what you have presented, sir, we can see that there is a knee and hand sign and symptoms. So is it also possible in a shoulder area?
For the shoulders, there can be a lot of sources of pain. So it can be periarticular involvement or it can be the joint. So might as well, my advice would be might as well consult a doctor to see where the pain is coming from in this patient.
Okay, thank you very much, sir. So since OA, sir, is already the failure of the synovial joint as an organ, our participants are also wanted to know if it is already a long-term condition. Is there no cure for this? And is this if that is the treatment in general a lifetime treatment?
Okay, so let me just highlight this. At the moment, the best that we can do for osteoarthritis is to manage the pain. So we don't have any medications at the moment that can actually reverse the process. So once you are diagnosed to have osteoarthritis, that is already a lifetime diagnosis. Okay, but it doesn't mean that you will always be in pain. So if you go to a doctor particularly a rheumatologist, then they can manage your condition well, and then manage your pain better.
Okay. So we need to have we need for the patients to go see their fellow rheumatologists now for this. They need to know that there are non-pharmacologic measures, there are medications, there are supportive therapies, and if these are not helpful, then possible consideration of surgery as well for this. So regarding food, sir, bawal ba ang munggo sa may arthritis?
So it's a common misconception that there's
Yes.
just one arthritis. So mungo is more related to elevating uric acid. So this is more related to gout. But for osteoarthritis, it's really not related to food unless you are overweight. So that's the only association with food intake. But you don't need to lessen a specific type of food for osteoarthritis. Just eat moderately and maintain an ideal weight or as close to ideal weight as possible.
Okay, sir. So there is no better form of diet for this subset of patients, sir?
No particular diet.
No
Okay.
particular diet. So usually, mga tinatanong ng mga participants natin, are there any specific diet, what food to avoid? So right now, we don't have any specific food, no? Okay. So another part of the core treatment, sir, is exercise. So what are the simple exercises that we could recommend to our patients? What are the recommended exercises for
Okay.
osteoarthritis?
So actually, I highlighted this in the talk a while ago. Always include stretching, cardiovascular, and strength training for your exercises for your osteoarthritis. So there's no particular exercise that is best for all patients. So you need to individualize depending on the patient's profile as well. Okay? So for example, kung your patient is having a hard time doing jogging because of knee pain, then probably a good alternative would be just walking or the use of stationary bike. So it will have less impact on the knees. Or if it's available in your area, water aerobics can be good also for knee osteoarthritis because it lessens the impact on the knees.
So in general, sir, we need to prescribe low impact exercises for these patients, no? As well as strengthening exercises with increasing tolerable load for them. Okay. So, sir, there's also another question regarding chiropractors. Is it safe to see a chiropractor in a patient with osteoarthritis?
That's a good question, but let
Yes.
me just thread this a little bit. Baka there might be some chiropractor in the audience. Okay, it's not part of the mainstream treatment for osteoarthritis. Okay, if you think you will benefit with the use of chiropractic in the management of your OA pain, then I will not discourage you to do so. But it's not part of the main treatment for osteoarthritis.
Okay, sir. Thank you for that. So now we will proceed to the pharmacologic treatment. No, I gathered the questions regarding glucosamine, sir. So based on your systematic review of clinical practice guidelines that you have presented earlier, actually there is no consensus po, no, for shoulder OA, and actually it's do not do in hip OA. So is it okay to use a combination of glucosamine and chondroitin? And are there any side effects for long-term use of this combination?
For glucose, okay, let's just start with nutraceuticals. We had a recommendation for this way back in 2008 in our Philippine guideline for osteoarthritis. And then there we already stated
that combination of glucosamine and chondroitin might not be effective in patient. And the explanation for this one in recent literature is that they might be contradicting the effect of one another. So what is recommended at the moment is to use each of these nutraceuticals as a separate treatment. So the glucosamine sulfate is more recommended for knee osteoarthritis, and then the chondroitin sulfate is recommended for patients with hand OA. And the combination might not be effective for each of these conditions.
Okay. How about the side effects, sir, of glucosamine and chondroitin?
Actually safe, very safe to use on a long-term
Very safe.
basis. I think the longest that for glucosamine sulfate, the longest for the randomized control trial is up to 3 years. But from a personal perspective, I've been using this in patients even as long as 10 years, and we don't see any side effect. And even the literature would tell you that they are safe in patients even with diabetes. Ano? So yung glucosamine doon is sugar, the glucose part. So it doesn't have any impact on patients with diabetes as well.
Okay, sir. Is in a preparation of sachet form, sir, no? Or is there a new preparation for glucosamine?
The recommended dose is 1,500 milligrams per day. So wala pong hindi po effective if you use the lower dose. If you're going to start this medication, maintain it at 1,500 milligrams daily. You can see the effect as early as 1 month of continuous use. And if it's effective for you, then you can use it indefinitely. Now, dalawa po yung preparations in the market. There is the sachet form, para siyang sugar that you dissolve in a glass of water, and then the other one is a tablet. So if you're taking the tablet, you need to drink 3 tablets of 500 milligrams per day. Para sa sachet, it's already 1,500 milligrams, and then you can take it as once a day. And then the best time to take this is at least 30 minutes before eating. Okay.
Thank you very much, sir. So regarding the Locoa patch, sir. So I have a few questions regarding esflurbiprofen patch. So can we use the pain patch to any kind of joint pain, not just in osteoarthritis? I think some are asking if it can be used in inflammatory types of arthritis like gout, rheumatoid arthritis, or lupus. And is a need for a prescription for this type of patch, or is it available over the counter?
Sige, I'll go with the last question kasi mas
Okay.
madali yan.
So dali
So
ka, sir.
it's a prescription drug. So you cannot buy it as an over-the-counter drug without any prescription. Okay, and then second, ano yung tanong mo ulit, James?
If we can use the Locoa patch, sir,
Okay.
to any kind of joint pain like gout pain.
Okay, so the main indication as approved by the FDA is for OA pain. Okay, but as an off-label, you can try with
Can try.
other pain type. If it works, then that means theoretically it's an NSAID, so it should work in other pain conditions as well.
Yes, sir. I think sa mga gout patients, especially since part na rin naman po, sir, yung NSAIDs as treatment for gout flares, no? But for other inflammatory arthritis like rheumatoid arthritis or lupus, I think we need to treat the underlying cause for those.
Yes.
And you can try to use the Locoa patch if it can help alleviate the pain, if that's our goal for that. Okay, sir. Another question, sir, regarding PRP, sir, platelet-rich plasma. Is it a good therapeutic option for osteoarthritis? And how frequent can a patient have PRP injections?
I think in the recommendation of the CPGs, it's still part of insufficient evidence. So there's really no strong evidence to recommend the use of platelet-rich plasma injection. But again, it will depend on how your patient will perceive this alternative modality. If the other modalities, short of a surgery, is not good to your patient. Okay?
Okay,
So I
sir.
will leave it to the attending physician to whether use this particular kind of modality or not.
Yes, sir. So currently, there's still no consensus in the recommended use of PRP. We still need a lot of future studies regarding its effectivity and safety. Okay. So right now, I have questions, sir, regarding the other medications that could be related to osteoarthritis, no? So calcium and vitamin D supplements, can they reduce the chance of having osteoarthritis?
For calcium, actually, calcium is better for patients with osteoporosis
Yes, sir.
as a
Osteoporosis.
supplement. Okay, but we still don't know if they have a role for OA. For vitamin D, there are studies saying that it might decrease joint pains in a lot of arthritic condition, but the efficacy for particularly for OA patients, we still need to see stronger studies to support the use of vitamin D. And again, calcium and vitamin D would be better for patients with osteoporosis rather than osteoarthritis.
Thank you, sir. So in relation
Okay.
to that,
Let me
yes,
just
sir.
add siguro, James, OA and osteoporosis can occur in one
In
patient.
in one
Okay.
patient, yes, sir.
So if you have osteoporosis, then you can use calcium and vitamin D.
Yes, sir. Most of the subset of osteoarthritis, especially the elderly ones, maybe they could have a concomitant osteoporosis. So
Okay.
aside from treating the osteoarthritis, we need to screen this subset of patients for osteoporosis. So another question, sir, regarding collagen. Is collagen can lessen the progress of osteoarthritis, or is it helpful for patients with OA? I think this is collagen supplement, sir.
Yes. There's still insufficient evidence for that, okay, for the use of collagen. But I know there are supplements available in the market, and a lot of our patients are using these collagen supplements. But whether it is effective or not, we still have to wait for the verdict from better studies.
Okay, thank you, sir. So right now we have a question regarding when do we refer to our orthopedic colleagues or surgeons in osteoarthritis patients? And I think pwede ko din idagdag dito, sir, when do we refer them to rehab medicine service? And what do we instruct on to our rehab service regarding the prescription or what sessions that we can do for these OA patients?
Okay, for siguro mas madali yung rehab.
Yes, sir.
For
Rehab
rehab,
first.
you can actually refer them early. There's a new study just published a few weeks back that shows that if you refer patient earlier, those with early symptoms of OA less than 1 year, they respond better to rehab treatment compared to those who have pain already more than a year. This is just a new study, so it's not part of my lecture anymore, but I just would like to share it here. And then for rehab, for surgery, uh, as as long as the patients are already not responding well um, to non-pharma and pharmacologic measures, then you can refer them to your orthopedic surgeon. You don't need to wait na parang naka-wheelchair na siya. As long as your patients are telling you the present modalities, the non-pharma and pharmacologic treatments are not working, then you can refer them already to the ortho.
Ortho. Okay, sir. Thank you for that. So aside from the knee OA, we also have questions regarding spine OA and hip OA. So for the spine, sir, what diagnostic tests would you advise to confirm the osteoarthritis for a patient with back pain?
Okay, medyo varied yung low back pain. So that's why
sir.
a lot of the research are concentrated on the knee and the hip and even hand OA, because for low back pain or back pain in itself has a lot of etiologies. So probably you need to consult a doctor to see where the pain is coming from and whether it is osteoarthritis or another condition.
Yes, sir. Kailangan po talaga, we need to know the history of the patient. Baka naman may accident siya before, or we need
Yeah.
to examine them. Maybe there's an underlying neuropathic component. Then regarding hip osteoarthritis, sir, what are the treatment options if NSAIDs like our Coxar Flanax, they don't seem to work anymore? So what can you suggest, sir, if the hip OA is refractory to NSAID therapy?
You need so that's one indication for doing an imaging study.
Sir,
So
yes, sir.
you've already tried an NSAID, it's not working, patient is still symptomatic, then probably number one, you need to see whether your diagnosis is correct, or you can do an imaging study, either an X-ray or you go to a higher resolution imaging and then see where the pain is coming from. For all you know, baka surgery na rin ang best treatment for this patient.
Surgery na natin, sir. If ever na hip, no? O may nakita tayo, sir, na problem. So, sir, regarding what age is your youngest OA patient, sir? Because currently we have a growing or increasing number of early onset osteoarthritis, right, sir?
40s, I think mga early
40s.
40s, mga youngest ka. But in the literature, particularly in the global burden of disease study, yung sa 2019, they looked at the incidence of OA from 1990 to the present, which is the 2019 data. And they saw that more than half, a little bit more than half, parang mga 52% had early OA. And ang definition nila for early OA is somebody who has OA at less than 55 years old.
55.
In the newer data, yung sa Global Burden of Disease Study 2020, they're looking at yung sa working age group from 30 to 59 years old. And the prevalence is about 3.5%. Okay, so meron na rin sa mga younger patients.
Yes, sir. Very important, especially since if lalo na, sir, no, may increasing obesity na rin sa mga younger population. So marami talagang comorbidities, can produce more burden, especially baka maaga sila magkaroon ng job loss or absenteeism sa job nila. So I really need to consult a rheumatologist in this early onset OA patients.
Dagdagan ko lang yan, James, because you mentioned about obesity. In this
Yes, sir.
study, Global Burden of Disease Study 2019 and in 2020, they highlighted that yung important risk factor for a lot of these young patients or even in patients with OA is due to overweight or obesity. So they parang estimated the contribution to the risk is about 20%. It's the only risk factor that they were able to measure in the global burden of disease.
Okay, sir. Very important. Yung modifiable, it's part of the modifiable risk factors, the obesity. So I think that's one of the key preventive strategies that we can recommend to our patients, no? Even before the onset of disease, the clinical symptoms of OA. So I think we have answered majority of the questions na, sir, with all of the aspects of your lecture. So this afternoon, thank you, sir, Dr. Lucero, for answering those questions. So I'm sure our audience learned a lot from you today. So thank you also to our audience for their interesting questions. So